It's my great honor today to join APACC on the topic of current issues in antiretroviral therapy in pregnancy. In this era when the access of antiretroviral treatment is worldwide, therefore the antiretroviral therapy in pregnancy has changed the phases. So maybe half of the patients who are pregnant already received antiretroviral therapy before pregnant, which is a good news because we normalize HIV to be able to pregnant and be able to have normal family life. So I would like to address the topics of antiretroviral drug consideration in pregnancy, including timing of HIV diagnosis, whether the patients had already received ART pre-conception or just start during pregnancy, and whether they were antiretroviral experience or already are interrupted treatment or naive just start in pregnancy. And also importantly, even though pregnant women is like similar to adult living with HIV, but physiologic change during pregnancy is a concern that maybe some drugs cannot be used during pregnant. The second part of my talk would like to address the ARV regimen during pregnancy, recommended from DHHS guideline from US and also British guideline. And the last topic is on new antiretroviral drugs. What is the updated data on dolutegravir and tenofovir alafenamide in pregnant women? And follow this session will be case discussion. This is the update of people living with HIV who are on treatment in 2019. It's interesting to see that now 67% of people living with HIV access to treatment. So this will reflect in the antenatal care. Maybe 50% of them already received ART. So how are we going to use antiretroviral therapy? I would like to divide into two parts. The first one is the context. In pregnant women, routine HIV testing was implemented at first antenatal care and repeat again in third trimester. So there are urgency in terms of how to start and what regimen that can bring viral load down to undetectable in order to have a benefit to prevent baby from infection. And also the treatment have to start rapidly, same day or rapid ART within 7 days in order to have longer period of receiving treatment. Mutation, start treatment rapidly, same day, regardless of CD4 or viral load. And the last one is on the family approach. Whenever we use antiretroviral drug in pregnant women, we have to care the effect on the infant and also the transmission risk to partner and also the plan for the subsequent pregnancy. So if the treatment was start in the first trimester, most of the concern would be on birth defect. If in the second trimester, it's need to make sure that the patients have adherence to treatment and also have a chance of viral load monitoring to make sure that the risk of transmission will be low. And for the one who was just diagnosed in third trimester as an incident case or had just diagnosed later, have to be prioritized on the regimen that have rapid viral load suppression and also high placental transfer. So in terms of the antiretroviral drug that we use in adults, which regimen that have rapid time to viral suppression? That one would be integrase inhibitor class. It's higher than boosted PI. For pharmacokinetics, are there any drugs that have to be concerned? In general, in third trimester, the level of antiretroviral drug would be less than postpartum. And the one that have contraindicated is cobicistat booster enhancer regimen because it will be reduced blood level and might not have adequate efficacy. And also may be true for ripivirine that the level might not as high in third trimester that may have some effect on the efficacy. Adverse events need to be careful on the adverse events that was also related to pregnancy, such as anemia, vomiting, or dizziness. The next one is on the transplacental transfer. We would like to use the regimen that have high transplacental transfer in order to provide enough blood level for neonate as a neonatal pre-exposure prophylaxis. And the last one is on adverse pregnancy outcomes. Dolutegravir is the one that have increased risk of birth defect that need to counseling families to understand this risk. And also the risk of HIV transmission. I would like to emphasize that the timing of antiretroviral drugs is critical for pregnant women You can see that if ART starts before pregnancy, the risk of transmission is only less than 1%. But if the ART less than 4 weeks, the transmission rate is going up to more than 7%. So what is the recommended guideline? This one is DHHS guideline. So it's divided into preferred regimen, alternative, insufficient data to recommend for new drugs, and also not recommended. So what is NRTI to use? They recommend abacavir 3TC or TDF FTC or TAF FTC because it has once daily regimen, and also it has high placental transfer. Sadovudin and 3TC was shifted to alternative because of the twice daily regimen. In terms of what is the third drug, NNRTI such as efavirenz that has been used as a first line in many guidelines is now changed to alternative because of the risk of baseline drug resistance. And also they have lower efficacy comparing to integrase inhibitors. In this slide, the blue alphabet is mean that the regimen that need to use as a twice daily regimen. So that one is maybe an issues that need to be concerned in terms of adherence to treatment. For boosted PI regimen, the only two regimen that was recommended is atazanavir-ritonavir or darunavir-ritonavir. And what is recommended from BIVA guideline? From BIVA guideline emphasize on how to use dolutegravir. If patients already on dolutegravir and wishing to conceive, they should counseling about the risk of neurotube defects and also advise to start folic acid 5 milligrams once a day. For women who are already on dolutegravir who becomes or is pregnant, usually the neurotube was closed within 6 weeks of conception. So in general, we don't need to change the regimen. However, if the parents has a concern, would like to switch, we can switch to efavirenz or atazanavir-ritonavir. So the last section is on the updated of the new drugs. I would like to emphasize on the data from the APACC 2010 study that was compared DTG versus efavirenz, and also compare between TAF and tenofovir disulfiramate. So in terms of dolutegravir, in this study, they give treatment regimen for second trimester in 3 arms. You can see that for combined dolutegravir arms, 97.5% had undetectable viral load at delivery, which is higher than efavirenz. So it's mean that dolutegravir has better virological control than efavirenz. However, there are 2 HIV transmission in DTG arms. In terms of adverse pregnancy outcomes, comparing between TAF and TDF, you can see that TAF has lower any adverse pregnancy outcome, especially to preterm delivery. So it's promising that TAF can be used in pregnant women. In terms of late pregnancy, Dolphin study, this one in 3rd trimester, women who are already in 3rd trimester randomized into dolutegravir versus efavirenz. So it's similar that dolutegravir had better biological suppression rate at delivery. However, they also see that there are 3 mother-to-child transmission events in DTG arm, and all occur in utero, and also higher risk of stillbirths, which investigator consider that is unlikely to be ART related. So this one, we need more efficacy, effectiveness data when we use more dolutegravir in pregnant women, that even though it had viral suppression at a higher rate than efavirenz, but what is the effect when we have in terms of HIV infected status in infants and also the adverse pregnancy outcome. So this one, you can see that why integrase inhibitor is highly recommended in 3rd trimester, because the time to viral suppression is significantly faster than efavirenz comparison group. So in summary, I think antiretroviral therapy in pregnancy, the first important thing is identification of pregnant women living with HIV, either at first ANC or before delivery, and also rapid start treatment regardless of CD4. And the current preferred regimen is 2 NRTI plus integrase inhibitors, dolutegravir or raltegravir, or plus boosted PI, atazanavir or darunavir. And the outcomes we need to be concerned for both mother and infant for HIV transmission and also pregnancy adverse outcomes, especially SGA and preterm, because in some settings, these adverse outcomes also related to morbidity and mortality of infants, even though they are not infected with HIV. So we would like to continue in the second part, which is this case discussion, to integrate this overview into case management, and also have the important part of how to manage patients during delivery and also neonatal management. Thank you.